every time we have an author, it's absolutely amazing because folks that have written books have done so much research and dove so deep into a topic that they really are able to present us with very objective, informative information. And it creates a very thought-provoking discussion. And if I didn't mention it already, we love talking to you, the audience members. So if at any point today you have questions, comments, what have you. But without further ado, let me introduce Allison Applebaum to the stage. We'll welcome Allison, and the first thing we're going to do is get to know her a little bit better, and then we're going to dive into this topic and the book that she's written. Allison, number one, thanks for joining us today from New York City. We're thrilled to have you. As Let's get to know you. Tell us a little bit about yourself and what led you to this career path.
Well, first, thank you so much for having me. I'm really excited to be joining your community today and all of you. I'm a clinical psychologist by training. I am, as of just a few weeks ago, a professor in the Brookdale Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine at Mount Sinai, where I'm also the director of a very new center for caregiving. And my work over the past 15 years has focused on addressing the profound unmet psychosocial mental health needs of family caregivers. Before my current position, I was at Memorial Sloan Kettering Cancer Center, where I was working primarily with caregivers of patients with cancer. And really, the Cliff Notes version of my story is that when I began working there during my postdoctoral fellowship, I was working primarily with patients at end of life. And really what was so striking to me is that in sitting with these patients, realizing that their narratives were not so much focused on their own fears of their own mortality per se, but on their parents and partners and children and siblings and friends. The
Wow.
individuals who were left in the waiting room, left at home, individuals who they were identifying as the people who were really central to their care. And of course, those who would be most deeply impacted by their eventual deaths. And I realized back then, this was 2010, and this was, of course, long before the pandemic, our most recent pandemic, that cancer care specifically, but healthcare more broadly, was so very dependent on family caregivers. And yet our healthcare systems were doing little to nothing to provide training or education or support. And despite the fact at that time, there was a very large scientific literature documenting distress in caregivers. At that point, there were no targeted services for caregivers in any cancer center or hospital system in our country. And so a year later in 2011, I founded the Caregivers Clinic at Memorial Sloan Kettering Cancer Center, whose mission is to assure that no caregiver experiencing significant distress as a result of their critical role goes unidentified and deprived of necessary psychosocial services. The clinic provides support to caregivers across the entire illness and caregiving trajectory, from a patient's diagnosis through bereavement. The clinic was, for too long, the only one of its kind. I'm happy to say that it is now serving as an exemplar to other hospital systems. And I and colleagues are working diligently to assure that in the next decade, not only will every cancer center have a support program for family caregivers, but more broadly, every healthcare system will.
Wow. Okay. I just pulled up the website for the Sloan Kettering Caregiver Clinic, which I'll
Mhm.
share with everybody. But that you answered my question. I was like, I've never heard of a medical system having a caregiver
Yeah.
clinic, and uh, this really sounds like a no-brainer that any and all healthcare systems should have something like that. It just seems like
Agreed.
a blind spot that
Huge
is,
blind spot, huge blind spot. That website now has taken off my information since I left 3 weeks ago. They're very quick
yeah.
to do that. But one thing I want to say is one of the steps that I took early on, and this has been one of the challenges I've heard from other healthcare centers, is that we actually register caregivers to become patients of the healthcare system at Sloan Kettering. That means, very importantly, they get their own medical record and their own medical record number, which is, of course, able then to address any issues around privacy or confidentiality or the billing practices of services rendered. So it's really been a nice exemplar of a model that works. And we've been up and running since 2011 with serving thousands of caregivers since then. And so now my mission and part of my career shift is basically now I'm going to take the model of care that we've demonstrated works and disseminate it across the US.
I love it. This is really exciting and sort
Thank
of
you.
unexpected. I was all, hey, we're going to talk about your book today, but
Well, we
that,
can. We
yeah,
should.
but that as a topic, I think is another thing where we could probably spend the whole hour talking
For
about it.
sure.
Now,
For sure.
before we dive into the book, I just want to acknowledge something that you shared that has probably been articulated in conversations that I've had before, but for whatever reason, it didn't get through my thick skull. And that is that, when people are at end of life, they're not as concerned about themselves and their well-being. It's those people around them that they're leaving. And I have found this to be true, but never sort of connected the dots in the conversations that I have with people that are concerned about end of life. I really appreciate that you've articulated it. I also think, and I'm curious at your comments on this, there's I've seen all the surveys that one of the main fears that we have is dying alone, and my gut level feeling is that is a fear that you have when you're far away from end of life, or all of us are literally minutes away from end of life, but I'm saying conceptually,
Yeah. Yeah.
does that make sense what I'm trying to say? And have you found?
Absolutely. Yeah, absolutely. And I just want to be very clear. I mean, of course, it was a subsample. I mean, I think that year I probably worked with about 100 patients at end of life. And that was just striking to me again, that they were so much less concerned about their own experience. I mean, yes, there were concerns about, will I die in pain and where will I die? But it was really what they wanted to talk about was not themselves. It was their family caregivers. And in terms of isolation, yes, I think that's spot on. I think that when you have some temporal distance from death, and of course, none of us know when, but assuming you're living with a life-limiting illness and you have an awareness of time coming to an end, I think the closer you get to that point, the isolation becomes less and less of a concern. And often more of what I hear is really around symptom management, concerns about quality of life, pain. Again, am I going to die in pain? What can we do for the pain? How can I remain comfortable? Can I be at home? Can I be in the hospital? I mean, not everyone wants to die at home. I want to be very clear. But yeah, I think you're right on that point, Steve.
All right. Well,
Yeah.
let's dive into the book.
Okay.
But boy, you brought up two the topics that I could probably talk the whole time. So you wrote this book, Stand By Me: The Guide to Navigating Modern Meaningful Caregiving. Tell us what inspired this, and I'm always curious at the process that authors go through to put together books. And then, folks, what I'm going to do while you're answering that question, I'm going to pull up the chapters of the book, and maybe we can talk about a few of the chapters.
So the same year that I founded the Caregivers Clinic at Memorial Sloan Kettering Cancer Center, 2011, is a year that I primarily identify as stepping into the caregiving role myself for my father, Stan Applebaum. Very briefly, my dad was an incredibly prolific, masterful musician. He was a composer, arranger, orchestrator, conductor who worked with many of the big artists of the 50s and 60s, including Benny King, Neil Sedaka, Connie Francis, Brian Hyland, among others. And I share this because my dad is perhaps best known for the string line that he wrote for Benny King's Stand By Me, which is in part why the book is titled Stand By Me.
Wow.
So my dad, so any of you who've heard Stand By Me and you've heard I'll just share the string section in the middle that sounds like a full orchestra, that is a Stan Applebaum composition. And so you all have already met my father in some way. My dad had me later in life. He was nearly 60 when I came into the picture. And he lived until basically 90 with only minor medical problems, but had a series of hospitalizations. And during one, a medical mistake put him into a coma. And there was one silver lining of the coma, and that is that it gave his team of doctors a hint based on the medication that led to the coma, that he might have Lewy body disease, which is a progressive neurodegenerative disease that leads to fluctuations in autonomic functioning and consciousness, which is what my dad had. My dad would have sudden drops in blood pressure and temperature to near hypothermia levels, and most often he would hallucinate. And he would hallucinate anywhere from a few minutes to a few hours. Occasionally, it would last an entire day, and one point, it lasted an entire week. And I personally had no idea how long these hallucinations would last, and I experienced each one as a mini death because he was unable to engage with me meaningfully when he was hallucinating. However, when he wasn't hallucinating, when he wasn't experiencing any sort of infection, he was completely oriented. He had his short-term and long-term and working memory, his zest for life, his creativity. He was still writing music from his hospital bed. And so I was tasked with taking care of him in the setting of an incredibly complicated illness journey, which unfortunately was punctuated a year later by my mother's sudden death. And so I was tasked with caring for him in the setting of trauma and grief for myself behind the scenes while leading our country's first support program for family caregivers in a hospital.
Wow.
And so I knew while I was taking care of my dad, and he and I spoke about this because, of course, I wanted his consent to write about him, that there was going to be a book that would need to be written, that I would want to share elements of our journey as partners in care to help to provide some guidance and assistance and support and validation to so many of the 53 million caregivers in this country. And so that was the original impetus for the book. It was born in my mind, I want to say somewhere around 2013 while I was sitting in an emergency room. But what really pushed me into writing was when we went down into lockdown in New York City in 2020. My dad died in 2019, February. So this was about a year later, and I was very isolated on my own and still very thick in grief. My dad was, aside from being an incredibly talented musician, he was an incredibly talented father. And he was my best friend. So my grief was intense. It's still present 5 years later. But one of the other challenges I faced concurrent to my grief was here I was leading this clinical service for caregivers. And because of the pandemic and all the challenges we all faced, our wait list got many months long. And I realized very clearly that there was only so much that we could do within this particular clinical service, and that I personally felt driven to do something that would allow me to help so many more of the 53 million caregivers of this country who don't have access to high quality psychosocial support. And so in writing Stand By Me, it's a narrative nonfiction compilation of my dual experiences, both as a caregiving scientist, I'm a clinician and a researcher, as well as my personal experience with my dad. And throughout, basically what I've done is provided you all with a Cliff Notes version to the type of training and education and support and validation that you might receive should you come to a caregiver's clinic. So I wanted to make it accessible.
Wow. And while you were chatting, I dropped this into chat, but you know that you are your father, I mean, his obituary here is on Billboard, the Billboard website with a picture of Neil Sedaka
Yeah,
there.
that's Neil Sedaka. I took that picture. My dad's sitting at the piano. That is the apartment I grew up in. That was
Wow.
taken about a year or two before my dad's death.
Man. What a way to ensure that, well, his legacy will live on in all of our ears and hearts. But this book and you're caring for him and helping us to be better caregivers is
Thank you.
a great legacy. So let's let's dive into the book here. So folks, as you can see, the book is organized, and also another impressive thing, I'll share the Simon and Schuster website. This book is published by Simon and Schuster, a major publishing outfit, but the you've got it organized into 10 chapters. And hopefully we can dive into a few of those chapters. But before we do, like, I'm always curious about the process of, how you had all this information, and how did you organize that? And
Yeah.
uh, how is the book organized?
How did I organize this book? I've thought about, I initially thought about what were the key topics that I wanted to address. What were those categories? And those included understandably acknowledging the distress and burden experienced by caregivers, the way the caregiving role can negatively impact all aspects of our lives. I wanted to give some, shine a light on that part. I wanted to, of course, as a clinical psychologist, to provide some guidance and sort of training in how do you navigate some of that distress, and in particular, how do you navigate sitting with uncertainty? And I focus on uncertainty because regardless of a care partner's illness, disease, site and stage of illness, cancer, if it's cancer, every caregiver, all of us in this room, Zoom room at some point as caregivers, are tasked with sitting with uncertainty. And so I felt the need to devote a chapter to that. My experience in caring for my father was very significantly colored by ageism. And so too have been the experiences of so many of the caregivers with whom I worked, among other isms. Let me be very clear, not just ageism. Yeah. So I felt a need to shine a light on the isms and how we as family caregivers can address them. One of the primary reasons caregivers have come to our clinic is because they are asking for guidance in how to have difficult conversations. So often folks would say, Dr. Applebaum, I don't know how to speak to my husband. Or Dr. Applebaum, am I allowed to can I speak up with the oncologist? Am I allowed to ask questions? And so it has become so clear to me since I began the program that communication skills are so very important. And so especially around the umbrella term of what we call advanced care planning, the planning for care we might receive in the near future and down the line. And so I spent a chapter focusing specifically on giving actual communication tips and tools, literally verbiage that you can use to open conversations and guide conversations. I felt that it was very important because for so many of the folks I work with, including myself, one's caregiving journey is very much colored by the availability of an extended care network, including home health aides or direct care workers. And so I wanted to make sure to spend a chapter focusing on the home health care workforce and really going through the steps one might take to integrate a home health aide or other direct care worker into one's care team, including potentially getting onto Medicaid, which I did, and really trying to just get out of the shadows, the complexity of the process, because it is such an overwhelming one. So I felt that was important. Inevitably, I knew there would need to be a chapter on grief because for so many of us, and not all of us, but for so many of us, our caregiving journeys end with the death of a patient, or at least the active journey does. And so I wanted to address grief. My work in my research, the research that I conduct and things that I study, one of the sort of the most major focus for me in the past 15 years has actually not been on all the ways that caregiving is challenging and difficult, but the ways that we can, despite the suffering of caregiving, experience meaning and purpose. And I've developed a psychotherapy called meaning-centered psychotherapy for caregivers that really helps caregivers to connect to meaning and purpose despite suffering. And I want to be very clear because I can't see your potential eye rolls out there. I'm not talking about the power of positive thinking. I'm not talking about turning lemons to lemonade. It's not who I am as a therapist or as a person. But the approach and the way that I work is really acknowledging suffering's real. Most of us don't choose to become caregivers. We're thrown into the role. I certainly did not have a choice. And yet we do have choice about how we can face certain circumstances in caregiving and how we can approach the challenges placed in front of us, how we can potentially create our lives in a different way while caregiving. Inevitably, so many of us, we grow as a result of caregiving. We learn new things about ourselves. And so I wanted to take take time to spend a chapter on meaning making and caregiving. And then
Holy
finally, I
cow.
felt that I needed to have a chapter where I talked about the various types of resources out there, because I know it could be so overwhelming for a caregiver when they're in need of support. Where do they look? And then I just want to acknowledge, as you look at the chapters, as you'll see, every chapter has sort of two titles, an initial title that's in regular font, and then a second title that's in italics. And so in the book, every chapter I've added a second title, each of which are songs that my dad either wrote, composed, orchestrated, or arranged over the course of his career.
Are you kidding? Wow. These are some iconic tunes. This is
Yeah. Yeah. And on my
and
website, you can find a link to hear all of them. I made them very accessible for you on my website. So
oh, I love it. And folks, I dropped that in there. Okay. Well, let's obviously every book and every story starts with chapter 1, and the title of that is Becoming a Storyteller. And maybe give us a glimpse of what you mean by that, because I know
yeah,
that it's very important in your philosophy and the
yeah.
guidance that you give with folks.
And it can mean a lot of different things. So when my dad was in a coma, I learned the most important lesson I would learn as a caregiver. And it was one that was reinforced for me every time he was hallucinating. And certainly every time I brought him to the hospital. He wasn't going to the hospital because he felt well and he was oriented. He would be disoriented or hallucinating or completely unconscious. I learned that without me there by his side to serve as his eyes, ears, and voice, that there would be no way for any members of those passing medical teams to have any idea who Stan Applebaum was and what mattered to him. That it was my job to convey my dad's personhood, what made him Stan Applebaum. And yes, certainly drop in Stand By Me was helpful in that, but also equally important was this is a creative man who has goals to live to 103. He's not done. And I realized that had I not been there to do that, that assumptions would have been made about my dad based on his age. So he was born in 1922. You throw 1922 out, right? There you go. His age and his cognitive status, right? The fact that he was unable to, in most cases in the emergency room at least, to communicate. And understandably, and I'm a healthcare professional, I work in a hospital, I've always worked in a hospital, I understand the reasons why these assumptions are made, especially in busy settings like emergency rooms, and yet they can be so very detrimental to the quality of care and quality of life of patients. And therefore, I felt it was so important to open the book by naming and labeling this very critical responsibility that, quite frankly, I think is really at the heart of what it means to be a caregiver. And yet, quite frankly, Steve, I had never seen in any book on caregiving it labeled or articulated clearly as a responsibility. And yet it was really what I was doing every day. And so I speak about telling one story, and I include in there some ideas for what to share. I mean, I think what's so important is that you are aware of what your care partner, what their goals of care are, and that goes into advanced care planning. But also relatedly, they're all interrelated goals of life.
Mm-hmm.
So for my dad at that point, after he had a very long hospitalization after the coma, and he was in and out of the hospital for about 6 months, and he became completely decommissioned. Before the hospitalization, he was basically doing everything independently. And afterwards, he was a skeletal version of himself that was bedbound. And unfortunately, he never fully recovered. And yet he was able to experience, from his perspective, meaningful life. He was able to sit at the piano. He was able to sit outside in the sunshine. He was able to listen to classical music together. We had meaningful conversations all the time. He found joy in the little things. And so it was important for me to convey that while, that might be a different quality of life than a particular physician might deem quality, for Stan Applebaum, that was quality of life, and it was life that was worth fighting for. And so that's why I felt it was so important to open this chapter. Our role as storytellers is important regardless of whether a care partner has a neurodegenerative disease or a cognitive who or someone who's cognitively compromised. But of course, it's that much more important if they're unable to communicate on their own behalf.
Man, boy, you are just full of gems here today
Thank you.
I mean that we've danced around these topics, but I just love the way that you've articulated this and put it together. And I think one of the things there's a couple of observations that I want to dive deeper in here, and if anybody else wants to jump in too. But the first is the the you know, we can see your dad's life story and I'm intrigued by it. You know, I mean, I'm just like, wow, I can't believe that he helped do Stairway to Heaven, hung out with Led Zeppelin, man. But it's important to remember that every one of us who has lived life on this planet has a story to tell. And you know, there are exceptional stories of politicians and you know, songwriters and things of that nature, but everyone has a very interesting story to tell, and that's our unique fingerprint. But I want to comment on this because you're right on. The healthcare system, like your dad in that bed in the hospital, is basically like, it's like he's sitting on the shoulder of Route 95 and the healthcare system is driving by and you are a stoplight, you know, that is like, get over here. And you know, you're advocating for him. um the what do you have any tips or insights on how can we make it easier for the healthcare professionals that are in this, you know, they're burning down Route 95 and we've got all these
Yeah.
interesting life stories, to get them to look at my father or my mother as the unique individual they are and not just a widget on a assembly line.
Yeah. That's such a good question. I mean, I think, look, inevitably, when you first bring a loved one or a care partner, I want to be very clear, not every care partner is a loved one. I get that. My
Right.
dad happened to be. Whenever you bring a care partner to the ER, in that initial moment, there's urgency to understand the medical picture. And so I encourage caregivers to prepare and maybe practice en route to the ER and the ambulance, if you're going via ambulance or you're driving, the one or two lines you can share that will give a summary of why you're there. So for example, my dad, Stan Applebaum. He's 93 years old. He has a history of Lewy body disease that's very well controlled. Yesterday, we were having meaningful conversations about music, and last night he came down with a fever and blood in his catheter. I think he has a UTI. My dad is a creative musician and he's not done living. He's not DNR. That
Wow.
I can say within 20 seconds. That gives very quickly the big picture, right, of what's going on. And that's what you would say to that initial interaction. Now, once the crisis has passed, we hope, and you have more of an opportunity to speak with a member of the team. And often you're going to find, you all know as caregivers, there can be an ally on the team, right? It's usually not the attending physician. It's most often the nurse on the team. You're going to find your ally who's going to listen and take more time to get to know the patient. And with that person, I encourage you to give more details about what quality of life looks like, what goals of life look like. And quite frankly, I encourage you, I wrote about this in the book, to depend on your iPhone or whatever phone you have. I was always taking pictures and videos of my dad, especially when he felt well. And so it was wonderful for me to say, you know, he's hallucinating right now, but 2 days ago, we were having this conversation, or this is my dad walking down the boardwalk, you know, a year after coma. Nobody said he could do that, but look at him, he did. And that was really helpful for me to illustrate to those who are taking care of him, to see that, yes, right now this man is frail. Yes, he's in his 90s. He can't communicate, but that doesn't mean that 2 weeks ago he wasn't sitting out on the terrace, drinking his favorite drink, Stewart's root beer, writing poetry. And this was a man who wanted to do more of that, right? And so I found it really helpful to illustrate in that way.
Man, just such wisdom through your experience as a practitioner and a caregiver yourself. And okay, I'm gonna pull up the table of contents again
Great.
because so many talking points on here. Um, I want to give you the opportunity to jump into any of these topics, but I will tell you there's two things that intrigued me when you were telling us your inspiration for the book, and the impact of ageism on caregiving. But then the other thing that you brought up was I believe you brought up applying for Medicaid.
Yep. Yeah.
Uh,
Yeah.
it first off, is there something on the list of chapters that you'd like to dive into? And but if not, I'd love your thoughts on those two.
Yeah. I mean, I can dive into those two for sure.
Yes,
So
let's start with ageism. Like
yeah.
you sort of said a few things that got me thinking, but your thoughts on ageism as it relates to caregiving.
Yeah, and it's very connected to what's in the first chapter. I believe it's the chapter. Well, now I'm I'm mixing up my chapters, which is embarrassing. I can tell the way you say hello. Well, actually, no, that's advanced care plan. So one thing I want to say is the chapters actually also build upon one another, and so the skills and constructs I discuss, there's a weaving through.
Okay, got it.
In terms of ageism, I mean, this was so prominent, right? Exactly. I can tell the way you say hello. Combating ageism and other forms of discrimination. Good. I wasn't wrong. I think I had an extreme example of this because in most circumstances, my dad and I represented the oldest and youngest partners in care in the emergency room. I was in my early 30s and he was in his early 90s, right? And so, we were this odd couple in the ER. Who are you, the daughter, the granddaughter, the friend? No, this is my father. But what was so clear to me right off the bat initially, right when he started to get sick, was how the date of birth on his hospital wristband led to so many assumptions being made about what type of care was appropriate to deliver.
Wow.
I'll give you an example. My dad had recurrent urinary tract infections, which are so common in older adults. And we learned over time with his neurologist that there was actually a neurodegenerative component to his Lewy body disease that had impacted his bladder and that was contributing to UTIs. And so his doctors thought him eventually getting what's called a suprapubic catheter, which is basically a tube that is surgically inserted into the bladder. It stays there, and then you have a catheter bag, would be a good idea, in part because my dad was having to have Foley catheters inserted, and that is no fun for anyone to have, and that's not quality of life. And so we had planned for my dad to have the procedure to get the suprapubic catheter put in, which is a minor procedure, doesn't take major anesthesia because, of course, with his brain, his neurodegenerative disease, that wouldn't have been great. But I remember one of the fellows or residents pulled me into the hallway and said, "You're going to put your dad through that? If this was my father, I wouldn't do that."
Hmm.
And I remember this was one of the more horrifying moments of I mean, I had a lot of horrifying moments actually, but I remember just saying, number one, that's my father in that room. Number two, this was his decision. But number three, this is a procedure that's going to improve his quality of life. And you're making a judgment based on his date of birth that he shouldn't have this.
Mm-hmm.
And so it just became so clear to me that ageism was something that he and I would need to combat. And I say he because when he was oriented, my dad could communicate on his own. He was a charmer. He could interact, and do a great job in conveying who he was. And so, he and I talked often about ways in which we could actually combat these assumptions. And most of the time it included him or I clearly articulating what my dad's goals were, his goals of care and his goals of life, again, which are very much intertwined with one another. I also, and this is where the chapter on telling the patient's story and this chapter are connected. I talk about in this chapter the importance of helping healthcare professionals to follow the platinum rule as opposed to the golden rule when taking care of patients. So the golden rule would basically say, do unto this patient as I would want done unto me. And that's what that fellow or resident was saying. I wouldn't do this because I wouldn't want this. But the golden rule completely leaves out the perspective of the patient. The platinum rule says, do unto a patient as they would want done unto themselves. And in order for any healthcare professional to follow the platinum rule, they need to know the patient. And the only way they're going to know the patient if that patient can't communicate is through you, the caregiver. And so again, I tie it back to sharing a care partner's story and personhood, that so much of what you can do to combat ageism is to share who your loved one is, and really make it clear to those who are taking care of them. I also talk about ways in which, of course, inevitably there are age-related changes that happen. My dad lost his hearing. I mean, that probably wasn't age-related. He was in music studios his whole life, right? He needed hearing aids. His vision was poor. His vision was degenerating because of the Lewy body disease. But anything that we can do to help our care partners to live life fully, hearing aids, glasses, anything else that can help one to be engaged, will actually help to combat ageism, because it helps individuals to engage in communication more comprehensively.
Man, Allison, you have been bringing up so many topics that I'm blown away that I'm not aware of these. I want to have you come back, or we're going to get
Happy
somebody
to.
to come back and
Yeah.
talk about the platinum rule.
Yeah.
Folks, so you can see I dropped it in there. The platinum rule is emerging as the new standard for person-centered care in healthcare, particularly palliative and end-of-life settings. I think you've really sort of opened my eyes up to how the golden rule lacks empathy. I mean, it's
Yeah.
basically saying that we all think alike and
Yeah.
do unto others as though we'd want to be, which is a great approach, I mean, in life. But but really it's not looking at somebody else's viewpoint. And
Yeah.
man, I,
Exactly.
my favorite discussions are on ageism. That's why I wanted you to comment on that. But I have never heard this angle of it, and it really makes a lot of
Yeah.
sense. Really opened my eyes up.
Yeah.
Now, the other thing, the other question that I had for you is about Medicaid, because
Yeah.
there are so many caregivers that are out there. I mean, I'm telling you, I get 2 or 3 calls a week for people that are sweeping in or falling into a caregiving role, and they start looking at their loved ones' bank accounts, and they're sort of like, holy
Yeah.
cow, am I going to
Yeah.
have to pay for
Yeah.
this?
Yeah.
So
Yeah.
tell us
Let me,
a little about what you learned there.
oh boy. Um, I'll preface this because I could imagine those of you who are like, wow, her father was so prolific, such a musician. Why in the world did he need Medicaid? I want to be very clear that the music industry in the 50s and 60s, a lot of things were done with handshake agreements. And so unfortunately, my dad wasn't necessarily making so much money off of those incredible songs that you hear. The
Mm,
producers were, but he unfortunately didn't get the type of financial compensation that was due to him. So I just want to say that because I know that assumption can be made. Both my parents were musicians. My mother was a concert pianist, very, very incredible pianist. But at the time that she died, she had very little savings, and my dad was living on Social Security and his pension from the Musicians Union. I was a brand new junior faculty member at Memorial Sloan Kettering Cancer Center, where my salary was not extravagant either. And I was tasked with figuring out how in the world I was going to take care of my father, and take care of all of his needs, including his rent, and everything else that his Social Security and pension checks were certainly not going to cover. One of the best things that happened in the first hospitalization he had, I should say, sorry, before that, my dad actually had taken out a long-term care policy, thank God. These are not as common these days. But his policy had a cap, as they often do. And that policy, it's now looking back, my mother must have foreshadowed something. I remember she said to me that the month before she died completely suddenly. No one knew it was going to happen. So she certainly didn't. But I remember she said to me, it's going to run out in a year. We're going to need to figure something out. And so I knew when she died that I had 9 months to figure out a plan, because there was going to be no money to take care of him. And so we had been paying out of pocket for home health aides through an incredible agency we found in New York City. And then I realized there was no way that we could sustain that. the first hospitalization he had after her death, I connected with a social worker, and social workers associated with medical teams are resources I strongly encourage you to rely on. This specific social worker encouraged me to get into touch with an organization in New York called the New York Legal Aid Group. Every state has an organization like this that provides pro bono, free legal guidance to individuals who are facing these crisis moments, including elder care and how can I get my father onto Medicaid. And in the book, I do actually provide a web link, website that is a search engine across the United States where you can find your correlate organization in your state. And so I worked with an attorney through NILAG who walked me through the process of getting my dad onto Medicaid. But boy, that Medicaid journey, it's quite complicated. I want to highlight a few things. Not only is it complicated because putting all the required materials together was more complicated than my doctoral dissertation. That was an enormous responsibility. But once we got approved for Medicaid, we weren't done. We were initially approved for just a few hours of care every day. And I ended up having to have a Medicaid hearing, basically go to Medicaid court to advocate that my dad, for whom his physicians had written letters saying this man needs basically 24/7 care, that it was like 4 or 6 hours a day wasn't going to cut it. And this was 2014. This was pre-pandemic. I did not have the gift or luxury to work from home. Boy, I wish I did. It would have made my caregiving journey much easier. But at the time, I needed to work, so I couldn't be at home all day long. And so I needed to have home health aides to take care of him. So I had to, number one, go to court and basically go through this process of getting it appealed. But then what happened once we got approved is that Medicaid sends the home health aide to you. You don't have a choice over who that person is, which was a second lesson I learned. And I remember opening the door so excited because this was the day life was going to get better. We have a home health aide. It's paid for by Medicaid. I can go to work. I'm not going to go broke. And I opened the door and a woman is there I'm a small build person, and this is a woman who was smaller than I. And my dad was full assist. He needed help with everything. He couldn't get out of bed on his own. And I asked her, can you transfer my father? Can you get him out of bed? And she said no. And so she left. And I ended up having to call to get an emergency aid. I think I spent $500 that day or something. It was like, how could I get someone last minute? And I realized that I had to take it a step further and enroll my dad in what's called a consumer-directed program. And these go by different names in every state, which would basically allow me to be me as his proxy to become a home health agency, hire aides on my own who would then subsequently get paid through Medicaid. So I'm going to take a step back. This, giving you a glimpse into my journey, of course, highlights the complexity of the journey. And I realized that New York State has one of the shortest wait times for Medicaid. So I actually think my Medicaid journey was on the shorter, easier end of the stick. And so much about this process was so shocking to me, Steve. I had no idea what was going to go into it. And so in chapter 7 of the book, Team Sports, I talk about how to implement home health care and direct care workers, and specifically walk through the steps that I took to get my dad onto Medicaid, as well as this consumer-directed program to really bring out of the shadows so many of the challenges that we can face. I think it's, being informed of the process early on is such a gift. And so I really wanted to demystify many of the steps. And I think, just even taking a step back further, it comes as a shock to so many of us that home health care is not covered by Medicare or traditional insurance carriers like Empire or, Aetna, for example, that this is not covered. And yet, for so many of us family caregivers, implementing home care is such a necessary part of caregiving. And so I wanted to make sure to spend a chapter on this topic.
Man, great stuff there. And folks, I dropped in. We did a discussion on understanding self-directed care and these programs that Allison is talking about. But buckle up, man, because even though there's these programs out there, like you said, it takes a lot of coordination. And I want to touch on that. And I mean, your father was so lucky to have you, but I wanted to talk a little bit about solo agers. But before I do, we got a great question from Anne, who says, do you offer insights for caregivers around caring for someone who's expressed wishes to end suffering when at the end of life? That is, to decline further medical interventions that may prolong suffering, but still on the path of death. Any insights on end of life wishes and things of that nature?
Yeah, I mean, I think it's number one, the most powerful thing you can do is listen and ask questions about what's behind those wishes. And if I hear correctly in this question, it sounds like it's common to what is the most it's similar to what is most common in these types of expressions, which is, I don't want to suffer. That there's going to come a point in my physical existence where going for the next treatment, next chemotherapy, next surgery, next infusion, next injection, next pill is just not worth it to me. And I think that it's important to acknowledge individuals' agency and choice. And of course that, we go into some gray zone there, and, I'm not going to open assisted, medical aid and dying right now. But, I think that one of the best things we can do to help those we love is understand what their fears are and then see how we can problem solve. My dad did not want, my dad he did want pain. He did not want pain. But also, and my dad, I'll be very transparent, he lived without suffering until the last 2 months of his life. He had suffering in the last 2 months of his life. He developed what I think is a malignancy on his leg. I have a fear that he had some sort of cancer that was spreading on his leg, having nothing to do with Lewy body disease, because he started to report some pain that was just overwhelming. This was maybe 4 weeks before he died. And at that point, he started not wanting to eat and not wanting to drink and disengaging. And I understood that to be him saying that this suffering is too much for me. And so my goal with him was, how can I alleviate the suffering and promote a quality of life for however long you have? And that, looks different for every person. But I think the best thing that you can do is learn in detail what their fears are as specifically as possible. I don't want to die in pain. I don't want to die like this. I don't want to die here. I don't want to feel powerless, right? So for many individuals, it's about control. And any way that we can help care partners who are living with life-limiting illnesses or disabilities to take control over their end-of-life experience is empowering, giving them choice in some ways. What would you like? How could we do this differently? Where would you like to be? You guide me. I'll be your eyes, ears, and voice, but you're the brain. You tell me. And so I think that could be really powerful. But inevitably, I also want to acknowledge it's really difficult for caregivers. Number one, it's really difficult to witness suffering. And number two, it's really difficult to hear statements like that. I know.
And also, I think the other thing that I really like, this is another great example of the platinum rule, is that we may have a different view of our own end of life. And it's important to separate that and like you said, to really listen to what this person is saying. And the other thing that I love about your what you've been sharing with us today is that, look, folks, advanced care planning is very important. Estate planning, having all of those documents lined up is great. But I really feel what Allison is sharing with us today is conversations and listening and interpreting for folks. So many times those documents are filled out, but because our loved ones never told us where they were, and we don't read them, we're going off these conversations.
Yeah, it's such an important point. I want to talk about this a little bit. So my dad, he had me when he was nearly 60. So, and he started to think about, he was planning for his death for a long time. He had no idea he was going to live. My dad died a week before his 97th birthday. He lived a very long life and very full life. And it's funny, I can laugh now. After his death, I found 2 sets of envelopes that he put together, manila envelopes, and on the cover he writes, "Open when I die." And one was written in the 90s and one was written maybe 2008. And had I depended on the information in these, manila envelopes, like I would have had no idea what Stan Applebaum from 2019 wanted. I bring this up because executing advance directives, healthcare proxy forms, power of attorney, DNR, DNI, living will. Yes, that's important. It's important, very important, by the way, that you're designated as healthcare proxy and power of attorney, because if you're not, you can't do any of that Medicaid nonsense. But very importantly, those conversations you have with care partners about goals of care, yes, they're scary. Yes, they're overwhelming, but they cannot happen once. These are conversations you must have repeatedly. What my dad wanted in 2013, when he was diagnosed with Lewy body disease, what his goals of care were then were dramatically different than his goals of care in 2019. And had I not had repeated conversations about his goals of care, there would have been no way when my dad died, and by the way, he did die in the ICU, and that there's many reasons for that, but there would have been no way for me to create an end-of-life experience that was as close as possible to what my dad wanted. The pain was uncontrollable at the home. I had to bring him to the hospital. So I share that because these are, it's what's really important. Yes, the documents need to be signed, but ultimately it's, will you, as the family caregiver, feel confident to bring your care partner's voice into the room? That's the real question, because that's the big responsibility we have, is to, if there's a time when a care partner cannot advocate for themselves, can you be that voice? And in order to be the voice, you need to have those conversations, and they need to be repeated, especially as illness shifts, treatments change, quality of life might change. Those are conversations you need to have again and again and again.
Man, this is so good. And what you're saying really resonates, especially as see Paula says, your story is so similar to the experience of the last 5 months with my dad. I'm now in the midst of this journey with my mom. And Paula, my big hug, for your situation, but I'm so glad that we were able to host something like this while you're going through this journey, and hopefully it gives you some ideas, and also makes you realize you're not alone. I mean, I think the loneliness of feeling like you're on this island and being a caregiver is so challenging, and there's just millions of other people that are out there going through the same thing. And I'm looking at the clock, and we're almost at the top of the hour. And on the topic of loneliness, Karen says, I work with solo agers who often have no one to speak for them. Having an advocate to know them and communicate is important, especially when family's not present. I want to bring up the topic of solo aging. Thank you, Karen. I mean, you're an incredible daughter, Allison. I mean, everything that you went through and the insights that you've gained, but it breaks my heart where people don't have advocates, and it doesn't mean that they never had kids. A lot of times our kids are all over the world, or we're just not connected, or we don't share the same, like we don't have somebody that can follow the platinum rule where
sure, exactly right.
Any insights that you sort of observed for those solos out there?
Well, it's number one, getting creative within the community. Like, who are your people, right? Who are, for so many folks, I mean, I remember when I use this word, I was going to say an orphan, when both my parents died, I had that feeling of being unheld as a human. And for a period of time, both my parents at points were my emergency contacts. And I remember who's going to be my emergency contact and getting creative. Well, what friend of mine is going to be the emergency contact, and having conversations about that. And so it's similar in terms of who else. It's not going to be blood family per se, but is there somebody in your world? It could be a friend, it could be a colleague, a neighbor that you could call upon in certain situations. And quite frankly, it's more likely that it's going to be multiple people. Maybe there's one person you can draw upon to help with some of the financial legal aspects. And there's another person who's going to be great at helping you get to a doctor's appointment. But I would say think creatively about who's in your social support network. Second, I would also encourage you to speak to, I'm saying you if you're a solo ager in the community, but speaking to a social worker associated with your medical team, because they often could connect you to volunteers within hospitals who would be more than happy to help you in situations. They can't serve as healthcare proxies or power of attorneys, but they could potentially assist with other caregiving related activities. And similarly, drawing on community-based supports. Many faith communities have volunteer groups who specifically want to help with medical needs and caregiving. And so, yes, it's going to take a little bit of effort and creativity. But I think for those who are solo aging, there are ways for you to build your own support network.
Yeah, I agree. And I know that it's one thing that I like about people that are brave enough to sort of verbalize that I'm on my own, I'm a solo and I need help is that they're planning ahead.
Yeah,
There's so many people out there that are just, oh, my kids will take care of me. I don't need to think about this type of stuff, and I love the solo aging discussions because we should all be empowered. And you can be married with a bunch of kids and a great network of friends, and you outlive them all, and you find yourself in a situation where you got to be creative. And I like that
exactly.
you stressed on that word. I was
Yeah,
talking to somebody the other day, and I know we're going to wrap up here. And Ruth says this is where villages can help. I expect absolutely, and I'm going to drop the Village to Village Network website in there if folks aren't familiar with the villages. It's great to research if there's a village in your community, because you will find that there are like-minded folks that are in your neighborhood that want to help and need help, and that's a great way to connect. But you've used the term creativity so many times in your discussion, and I applaud you for that. And I was just having a discussion the other day with somebody that it was, I guess maybe it's because it's an election year. They were sort of ripping on, the arts and funding of the arts or something like that. And I said to them, you recognize that teaching children artistic pursuits, whether it be music, painting, what have you, anything that expands creativity, it can be used in every part of our lives. That life is not sort of a three-step process. Life is guidelines that we've got to get creative to find the solutions. And I really am grateful that you've put an emphasis on creativity no matter what our situation is.
thank you. Thank you.
Man, Dr. Applebaum, this has been an absolute amazing discussion. It's
Thank you so much.
Tuesday. You have made my week. I am
Oh,
telling
awesome.
you, I am going to share this recording far
Please.
and wide because
Thank you.
you are really a treasure to the community. And I can tell by the folks that are all those hearts that just launched up there that folks agree. This is
Thank you so
going to be in
much.
one of my personal top 10 discussions here. Um,
Awesome.
I look forward to having you back on because there's a lot of rabbit holes we could dive
Yeah,
into.
for sure. For sure.
Um, and folks, thanks everybody for your participation. And I'll get this recording right up. It'll have the links to all of Dr. Applebaum's books. And for those people that are professionals in the audience, you're looking at what I think would be an amazing keynote speaker. If you're looking for a speaker at a conference, I feel really fortunate to have you here for this
So
hour.
much. Thank you so much, Steve. It's been so wonderful to be here. Thank you for all of your comments and your engagement today.
You bet. Talk to you soon.